and the therapeutic regimen based on the GBS DS scores. Now, how to diagnose? It is based on the guidelines published in 2023. Required features: progressive weakness of arms and legs, absent or decreased tendon reflexes in affected limbs, and progressive worsening in less than 4 weeks. GBS does not worsen beyond 4 weeks as per the current understanding. The supportive features of GBS is relative symmetry, relatively mild or absent sensory symptoms, having cranial nerve involvement, especially bilateral facial palsy, autonomic dysfunction, respiratory insufficiency, pain, and recent history of infections less than 6 weeks ago. Supportive lab tests: cerebrospinal fluid, increased protein and white cell count less than 5. The serology, especially in Miller-Fisher syndrome, identifying GQ1B antibodies may be helpful or increase the chances of making the diagnosis. Electrodiagnostically, nerve conduction studies will show the evidence of peripheral neuropathy. But in the early stages, it can be normal, so it needs to be repeated. The finding inconsistent with GBS are as follows. When there is an asymmetry, think of something else than GBS. Severe respiratory infections happens faster, especially in the first 24 hours. Most likely, different diagnosis than GBS. Predominant sensory signs: fever at onset, sensory level or extensor plantar response, hyperreflexia, even though initially the GBS can have hyperreflexia, as persistent hyperreflexia makes GBS unlikely. Having bladder and bowel dysfunction, abdominal pain or vomiting, nystagmus, alteration of consciousness. The only exception is Bickerstaff brainstem encephalitis, abnormal routine blood test, and CSF cell count more than 50. It pretty much excludes the possibility of GBS. So what are the differential diagnoses? What are the various diseases that can mimic like Guillain-Barré syndrome? The brain, encephalitis, it's easy to distinguish. These patients present with drowsiness and seizures and spinal tap will show pleocytosis. Brainstem stroke, hyperacute sudden onset, distinguishes from GBS. Transverse myelitis, sensory level, brisk reflexes, and MRI will show the hyperintense lesion. Malignant infiltration, again CSF pleocytosis, and they will have cauda equina syndrome. The infection of the anterior horn cells by different enteroviruses present as fever and CSF pleocytosis, and the normal nerve conduction studies. Microbiology will show the virus. Neuralgic amyotrophy, asymmetry, pain, findings limited to the nerves affected, distinguishes from GBS. And CMV HIV radiculitis, subacute presentation, again identifying HIV CMV serology, CSF pleocytosis distinguishes. Among peripheral nerves, let me kind of talk about this one later. Porphyria, family history, and raised urinary porphobilinogen, Lyme disease, history, characteristic rash, and serology distinguishes from GBS. Thiamine deficiency, again, it is associated with hyperemesis gravidorum and nutritional deficiency. And they will have abnormal thiamine levels and erythrocyte transcretalysis activity. Diphtheria, again, laryngeal infection, isolation of corynebacterium, diphtheria distinguishes. Critical illness, the history distinguishes from GBS. Metabolic and electrolyte imbalances, again, the electrolyte abnormality distinguishes from GBS. The one thing I left was CADP. In acute presentation, it mimics exactly like GBS. They will have albumin cytological dissociation. Nerve conduction will show demyelinating neuropathy, and the neuroimaging may show widespread enlarged nerve roots. That may be very distinguishing but it's not that much. So these patients need to be treated like GBS when there is a less response or persistence of symptoms put us back into chronic inflammatory demyelinating polyradiculoneuropathy. Neuromuscular junction, it's easy to distinguish, but one has to keep in mind myasthenia gravis, fatigable weakness, relapsing and remitting, botulism, rapid progression, pupillary abnormalities, dysautonomia, and descending paralysis. In GBS, we will have ascending paralysis. Lambert-Eaton syndrome, proximal weakness, depressed tendon reflexes, and autonomic changes. Muscles, diseases like inflammatory myositis and critical illness myopathy, they all will have increased creatine kinase level. And nerve conduction studies will be normal, EMG will be abnormal. Now, how to treat? Before we treat, how to predict the need for ICU admission. GBS can present with rapidly progressive weakness leading to respiratory insufficiency in hours to days. Typically, it does not happen in the first 24 hours, but it can progress to the level we need a support, respiratory support, the next day or two. So elective transfer to ICU may result in early recognition of the need for ventilatory support and intubation. Assessing the risk of respiratory failure early in course of GBS, very important. The way we can use is modified EGRIST or Erasmus GBS respiratory insufficiency score. What does that entails? It requires 4 clinical factors: rapid disease progression, bulbar palsy, weaker neck flexion, and bilateral hip flexion. The 4 elements needs to be evaluated and identify those patients so that they can be monitored much better in ICU than on the floor. Once you admit in ICU, regularly assessing the risk factors is very important, especially those patients who have GBS DS grade 4 and above. That means unable to walk 10 meters even with aid. They are bedridden. Neck flexion, facial and bulbar weakness, especially inability to cough, need to be assessed. Autonomic instability such as fluctuations in blood pressure and heart rate. Regular assessment of forced vital capacity, single breath count. When available, maximum inspiratory pressure or maximum expiratory pressure needs to be measured and monitored periodically. When you have elevated liver function test, infection with herpes simplex and CMV or electrodiagnostic features of demyelination, they are highly likely to have respiratory or likely to need respiratory support than otherwise. So when you have elevated liver functions and HSV CMV positive, it is preferable to watch in ICU than in the floor. Forced vital capacity should be checked 3 to 6 times a day, and most of the centers use every 4 hours. When there is forced vital capacity fall more than 30% of the predicted baseline should alert concern. If it is more than 30% fall in 24 hours, needs transfer to ICU. More than 50% decline from the predicted baseline, need for ventilation. The elective ventilations can be done when the forced vital capacity is less than 20 ml per kilo, and mechanical ventilation is inevitable when the vital capacity is less than 10 ml per kilo. The maximum expiratory pressure is less than 30, maximum inspiratory pressure less than 40 indicates the need for elective ventilations that needs to be considered imminently. After discharge from ICU, the frequent monitoring of potential late respiratory and cardiovascular complications. So even after discharging from ICU, one needs to monitor for the autonomic dysfunctions and respiratory insufficiency. How do you treat? There are 4 elements discussed in these guidelines: plasma exchange, intravenous immunoglobulin, corticosteroids, and other treatments. The most important thing that works are plasma exchange, intravenous immunoglobulin. Plasma exchange. Plasma exchange should be started as soon as possible. in GBS patients, especially when the GBS DS score 3 or more and within 4 weeks from onset. Current recommendations are 5 exchanges over 1 to 2 weeks with a total exchange volume of 12 to 15 liters in patients who are severely disabled. 2 exchanges in GBS patients still able to walk unaided. That means GBS DS grade 2, within 2 weeks you have to give 2 exchanges. GBS DS grade 3 and above, 5 exchanges over 1 to 2 weeks. Even in those patients who are still ambulatory but have fast rate of deterioration, risk of requiring ventilatory support, swallowing difficulties, those patients also need to be treated with a plasma exchange, 4 to 5 exchanges over 1 to 2 weeks, similar to GBS DS 3 and above. These are the two groups. They do not need plasma exchange when the GBS DS grade 1 and GBS DS grade 1 or 2 at weeks, but they are stable. In those patients, you do not need plasma exchange. Everyone else needs to be plasma exchanged. Next one is IV immunoglobulin. IV immunoglobulin is as efficacious as plasma exchange. The indications are very similar to plasma exchange. The GBS DS grade 3 or more needs to be treated 5 days in the first 2 weeks. The guidelines recommend the standard course of the treatment, which is 0.4 gram per kilogram per day for 5 days. There are other regimens available, 0.4 gram per kilo per day for 3 days, 0.4 gram per kilogram per day for 6 days, 2-day regimen of 1 gram per kilogram per day. The 2023 guidelines recommend stick to the standard course rather than other alternatives. There are few things very similar to plasma exchange. Even when the patient is GBS grade 2 within 4 weeks of onset, who has faster rate of deterioration, risk of requiring ventilatory support, swallowing difficulties, also needs to be treated with 5-day course of immunoglobulin. Treat GBS patients unable to walk unaided 2 to 4 weeks from onset with either plasma exchange or IVIG. Consider IVIG in GBS DS grade 2 within 2 weeks with stable but still deteriorating. In particular, and there are also other features of GBS. Those patients also need IVIG. So the indication for IVIG is very similar to plasma exchange. GBS DS score 3 and above, 5 days course. GBS DS 2 with the risk of fast rate of deterioration, risk of requiring ventilator support. Again, treat with 5-day course of IVIG. IVIG is not advised in GBS DS grade 1, that means milder form of GBS, and GBS DS grade 1 or 2 with stable, presenting 2 to 4 weeks from the onset of weakness. Is there an indication to give IVIG after plasma exchange or to do plasma exchange after IVIG? These 2023 guidelines do not support IVIG following plasma exchange or plasma exchange after IVIG. Current guidelines strongly recommends against the use of corticosteroids. And also it recommends against using IV methylprednisolone. Even though they are inexpensive, there is no trial evidence to support the use of corticosteroids in patients with GBS. In fact, the intermediate high dose of oral corticosteroid may even harm the GBS patients. Immunoadsorption and immunoadsorption followed by IVIG. The current guidelines does not support immunoadsorption. It's a technique to remove the possible pathogenic antibodies. So these guidelines do not recommend immunoadsorption alone or immunoadsorption followed by IVIG. Other pharmacologic treatments like eculizumab, it's a complement blocking agent. As we know, complement is important in forming the membrane attack complex, as we explained earlier. These guidelines recommends against using eculizumab because we do not have available evidence to support the use of eculizumab. And also these guidelines recommends against using other monoclonal antibodies like alemtuzumab, brain-derived neurotrophic factors, CSF filtration, cyclophosphamide, interferon beta-1a, muromab CD3, mycophenolate, tripteridium. So none of them are. So only two you need to remember is plasma exchange and IVIG. And the guidelines do not recommend neuromuscular electrical stimulation within 2 weeks after the onset of GBS. And again, it recommends against using 3,4-diaminopiridine to improve the muscle strength. So this slide shows and when to use plasma exchange and IVIG. As we discussed earlier, GBS DS scores more than 3. If you have a plasma exchange machine, use 4 to 5 exchanges in 1 to 2 weeks. If you don't, use IVIG over 5 days. In children, we prefer IVIG. Number one, IVIG is available in all the centers, easy to use. You do not need a machine to run, and we do not need a vascular access. As a result, IVIG is the preferred form of treatment. You can start early and you have to give for 5 days rather than 4 to 5 exchanges for 1 to 2 weeks. The GBS DS2, as we explained earlier, with deterioration, and you expect they may need a ventilatory support, those patients can be preemptively treated with exchanges, 2 exchanges in 1 week or 5-day course of IVIG. Those who have a GBS DS1, GBS DS2 stable, non-progressing, those patients do not need either plasma exchange or IVIG. During the follow-up, when there is a treatment-related fluctuation that is defined as initial clinical recovery and stabilization of treatment, then the secondary deterioration. These patients need to be treated again when those patients already received plasma exchange, given another course of plasma exchange. Those who received IVIG need another course of IVIG. There are certain clinical predictors to assess for respiratory failure and also inability to walk independently. Even though we discussed earlier, this is 4 parameters you need to assess, like rate of progression, bulbar weakness, weakness of neck flexion, and hip flexion. Inability to walk independently, we either use egos or modified egos. Age is an important factor, preceding diarrhea, and GBS disability score. My recommendation is confined to the one scoring system, which is DBS or DS or GBS disability score, because it is being followed across the nation and well studied. Most patients with GBS need to be treated with physiotherapy, speech, swallowing, and occupation therapy. Identification and starting the therapy when the patient is already in the hospital is the most important determinant of continuation of therapy after being discharged. These patients have lots of psycho-emotional issues. They need to be diagnosed and treated accordingly. As you can see, these patients can have depression, anxiety, stress, reactive psychosis, sleep disturbances, fatigue, that's more common, changes in daily activities, changes in work, sexual problems. They need to be identified and treated accordingly with appropriate personnel. Treatment of pain. The pain is an important component even initially and after during the recovery. These guidelines recommend tricyclic antidepressants, pregabalin, gabapentin, or serotonin noradrenaline reuptake inhibitors such as duloxetine or venlafaxine as a first-line treatment, even before tegretol or carbamazepine. So these patients benefit from giving any of those medications. We prefer gabapentin. So what is the role of yoga, meditation in improving emotional well-being? These current guidelines do not make any recommendation for or against using yoga or other meditational activities to improve the emotional well-being. Treatment of fatigue. Fatigue is more common, as you can see, 38 to 86%. Either you can use pharmacological or non-pharmacological strategies, like a graded exercise program, cognitive behavioral therapy, and physical fatigue management strategies can be used. This recommendation does not advise for or against exercise training for fatigue, but it's very unlikely that exercise would be harmful, so we recommend the graded exercise program. Definitely not only improve the muscle strength, and also it improve the emotional well-being of the child, of the patient. So now what are the risk factors for poor outcome? Meaning inability to walk unaided after 3 to 6 months. Older age, preceding diarrhea or gastroenteritis, higher GBS disability scores at admission, lower MRC sum scores at admission, decreased CMAP, that is compound muscle action potential amplitude. This concludes the seminar on Guillain-Barré syndrome based on 2023 guidelines. Please like our channel and share if you like it to other medical providers, medical students, postgraduate students, and other trainees. Thank you for watching.